Good evening. I'm Meg Von Maren, and I am happy to be here with my colleagues in the sarcoma program at Fox Chase Cancer Center. I'm going to ask each one of them to introduce themselves briefly before we get started with our program. So, Dr. Perfiglia.
Hi, good evening. I'm a surgical oncologist here at Fox Chase Cancer Center. I've been was a fellow here about a decade ago, and now been in practice at Fox Chase for 4 years.
Dr. Schulman.
Hello, I'm Dr. Schulman. I'm a radiation oncologist at Fox Chase, specializing in the treatment of sarcomas. I also trained at Fox Chase and feel very fortunate to have stayed.
Dr. Villano.
Continuing with the theme, I'm Dr. Villano. I'm a surgical oncologist at Fox Chase Cancer Center. I was also a fellow here, and I'm entering my 3rd year in practice at Fox Chase. I'm very, very glad to be a part of the webinar tonight.
Dr. Lee.
Hi, I'm Dr. Lee. I'm a medical oncologist. I did not train at Fox Chase, but have been in practice for 3 years and have been really glad to join the team here.
And Angeli Albanese.
Thank you. Hi, good evening, everybody. My name's Angeli, and I'm one of the social workers here, and I'm fortunate enough to be part of this amazing team of people that you see before you this evening.
Oh, and this evening, I am a medical oncologist. I too trained at Fox Chase. Many people have enjoyed working at Fox Chase and stayed on. We are going to start as presenting 3 different sort of scenarios of patients and how they might encounter sarcomas, and sort of talk through what we think about as our different specialties. We're going to try and take about 15 minutes for each of those, and then you all probably see the Q&A function. Please put in questions there, and we will take the last part of the webinar to try and answer your questions. So I'm going to begin and turn it over to Dr. Perfiglia, who's going to start with the first scenario.
Thank you so much. All right, good evening. So today I'm going to be discussing with some of my colleagues extremity sarcoma. So these are extremely rare tumors. In general, soft tissue sarcomas make up about 13,000 people in the US who are diagnosed each year, and almost 60% are located on the extremity and the trunk. These often present as a painless mass. So I have patients who come in and they bang their knee and all of a sudden they have a mass there, or they've fallen and all of a sudden they see a mass on their hip, but they're often not the cause of trauma. Like, trauma doesn't cause these tumors. Even though they start off as painless, they can become more painful as they grow, especially if they're involved, if they're pressing on a nerve or going into the bone or the joint. But usually those are more advanced or more aggressive tumors. Really, because of these extremely rare tumors, the key to treatment is multidisciplinary care, which is what we offer here at Fox Chase Cancer Center. You really want to be seen at a high volume center. So I'm just going to briefly go over a case presentation. This is just one example of extremity sarcoma. There are numerous out there. So I had a 45-year-old gentleman who noted a mass along his right knee. He stated that he had a meniscal tear of his knee, so he injured his knee and thought the mass was secondary to that. But over 6 months, the mass continued to grow, and he finally decided to get further workup. So a thorough workup is essential so we can really truly treat know how to treat the cancer. If the tumor is involving major structures like nerves or vessels or going into joints or bones, our treatment may change. MRI is the gold standard of how we assess soft tissue tumors of the extremity. In addition, we also want to get staging studies to make sure there's no evidence of metastatic disease or the cancer has spread. And here you can see that this gentleman had a 6-centimeter tumor on the inner aspect of his knee. So when I saw him in the office, clearly I could palpate this lesion. And we needed to get a diagnosis so we can figure out what the next steps would be. So we proceeded to go core needle biopsy in the office. And again, this is essential for how we diagnose our tumors. The other thing of note is that these tumors really should be biopsied by the surgeon who's going to be doing the operation, so we can really plan where our surgical scar is going to be to include the biopsy site. In this case, the biopsy came back as high-grade pleomorphic undifferentiated sarcoma. We again got a CT scan of the chest to make sure there was no evidence that the cancer has spread, which he did not. And then we discussed this case at our multidisciplinary tumor board. And at that point, we recommended upfront radiation therapy. And Dr. Schulman, I don't know if you want to discuss a little bit more about radiation and extremity sarcomas.
Sure. So, I feel very fortunate to work with a group of very collaborative and skilled surgeons. So we do discuss these cases at our multidisciplinary tumor board, and a lot of the discussion becomes whether or not there's a role for radiation. So there are several roles and indications for radiation. One of the main ones, certainly in this case, was high-grade disease. Radiation can significantly reduce the risk of local recurrence, the cancer coming back in the area it presented in. So we can deliver radiation before surgery, after surgery. We have a general preference for before surgery if we can do it, because we can deliver shorter treatment courses and deliver smaller radiation fields, but certainly there are also indications for radiation after surgery as well. Typically, we deliver radiation over the course of 5 weeks in the pre-op setting and about 6 weeks in the post-operative setting. But we are increasingly studying also shorter courses of radiation, which I think someday will become standard of care. Not currently considered so, but something we do discuss in certain cases. So as short as 5 treatments. Excellent,
thank you. So he proceeded with radiation therapy. Overall, he did quite well. This is the MRI of the area after radiation. I know it can be difficult to see for a layman, but before we had a big solid white mass, and now we have central necrosis, so some response to the tumor. Usually we want to wait a period of time after the radiation to make sure everything is healed, and then the next step is surgical resection. So really the goal of the surgery is we want to attain negative margins and get a good healthy amount of tissue around it to make sure the area doesn't come back again. So while at the same time we want to get these wide margins and make sure that we get it completely excised, we also want to make sure that we don't, we also preserve function of the limb. So if there's a major nerve or a major blood vessel, we often won't necessarily take that in order to spare the patient their limb. We also want to make sure that even though we get, again, negative margins, that there are some instances, even though if it's involving a major nerve, that we may have to consider amputation. But we really try with the goal of radiation before surgery to hopefully avoid this. There are some instances where we do adjuvant chemotherapy. And Dr. Lee, I don't know if you want to discuss this further.
Sure, thank you. So I think there are times when we meet people to discuss whether chemotherapy before or after surgery or a combination of that can be helpful. And I think this is another case where you really want to be seen at a high volume sarcoma center because the discussion is very, very tailored to each individual patient. I would say that, the indications for who should get this kind of therapy are not as clear cut as for radiation, but it does seem that when people have kind of a high enough risk of estimated recurrence, even after a successful surgery and or radiation, that's when we start to discuss, adding the chemotherapy. They also have to be able to tolerate combination kind of high dose chemotherapy, which can stretch over, 4 to 6 cycles over several months. And not everybody necessarily is kind of able to tolerate that in terms of toxicity and get the benefit from it. And so putting all of those things together, in an individual case by case basis is really important. Kind of in a broad rule of thumb, we kind of tend to think of things that are both high grade and extremely large, maybe like 10 centimeters or more is kind of an area where it makes sense to try to talk about this, but it really kind of has to be made also with the patient's input and their kind of goals and understanding of the situation.
Great. And Angelia, I don't know if you have any additional comments to make.
Yeah, thank you, Dr. Porpiglia. So, as you've heard from the doctors who have spoken before me, there's a lot of physical focus where everybody's sort of talking about what can they do to help treat the cancer. My role is more to focus on the emotional and mental part that kind of comes into play when someone tells you that you have a diagnosis of cancer. So there's oftentimes a lot of factors that go into that. Initially, people may feel things like shock, fear, trying to kind of come up with an organized plan. And so you see why having, coming to a comprehensive cancer center and coming to a place that has a multidisciplinary team is so important, because a lot of the communication can happen behind the scenes. And that way, when you come in, you're hearing a more formed treatment plan. part of ways, that I can help with that is, you can see that treatments take time, and oftentimes that can result in people needing to figure out, how are they going to work? How is this going to affect their daily life? What sort of daily functions are going to have to be allocated to other people? How are they going to manage a sort of day-to-day, talking to their children, talking to their loved ones? So these are all ways that we as social workers can be helpful, and why we encourage people to have these conversations, not just with your doctors, but, also kind of talking with us so that we can help guide you through the process.
Thank you so much. If you have any initial questions, we'd be happy to answer.
There are no questions currently in the chat, so if we can certainly move on to the next case, which Dr. Villano is going to lead the discussion on.
All right, everyone. Thanks for that introduction. Let me just share my screen. So I'm presenting on retroperitoneal sarcomas, which are another type of soft tissue sarcoma, also extremely rare, and something that we do see frequently, though, at Fox Chase Cancer Center, being a referral center for these. They encompass about 15% of all soft tissue sarcomas. And by retroperitoneum, we're largely speaking about a region of the abdominal cavity towards the back, kind of where your kidneys live, some big blood vessels, and parts of your colon and other intestines. Similar to extremity sarcomas, there are a bunch of different types. In fact, there are over 80 different types of retroperitoneal sarcomas, but there are several, maybe 5 or 6 that are the most common that we see. The thing about these is that they all behave differently from one another, and in some instances may warrant either radiation or chemotherapy in addition to surgery. And so as a treatment team, we find it really important that we have a thorough workup prior to pursuing any sort of treatment plan, so we know exactly what we're dealing with, and we can formulate a personalized plan for every single patient. Now, I'm presenting a case for a patient that, had a approximately 6 centimeter mass, similar to extremity sarcomas, because it can have very different types of symptoms based on where they arise. The thing about retroperitoneal sarcomas is that because the abdominal cavity is so large, they can be asymptomatic or not have any symptoms at all for a really long time until they get large enough to push on other things. And so this particular patient was having difficulties with eating, some symptoms related to reflux, and sought the care of one of her primary care physicians, who ordered a CAT scan and found this 6 centimeter tumor. After that time, she had seen a couple other providers and then was referred to us. She then underwent a core biopsy, which is a type of biopsy to understand what type of sarcoma this is. And it came back as a leiomyosarcoma, which for us, that's a type of sarcoma that arises from smooth muscle, which really for the abdominal cavity is from blood vessels. And so this particular tumor was arising from the blood vessel on her left kidney. And we have a representative CAT scan image here. Now, similar to what Dr. Porpiglia had mentioned earlier, the most important thing for these is being at a center that specializes in them, because the operations for these can be quite challenging. This one is actually, believe it or not, on the smaller size for a retroperitoneal sarcoma. And oftentimes it can be 15 centimeters or larger. So you can imagine 2 or 3 times the size of what you see on the screen, and they push on other organs. And so oftentimes we have to remove other organs in addition to the tumor itself. And so they're very complicated operations, and oftentimes we employ a team of surgeons even to remove them. So not just us, the surgical oncologists, but sometimes our colleagues in urology or other specialties to join us in the operating room to facilitate a safe operation. Now, we discussed her case at our multidisciplinary tumor board, which is what we do for all of our patients with sarcoma to formulate her treatment plan. And we had discussed with her the pros and cons of maybe pursuing chemotherapy versus going to surgery first. And she was most comfortable with getting the tumor removed with surgery as an initial maneuver because she was having symptoms. And so we went to surgery for her to remove that. And this is a representative specimen of that, and very classic for retroperitoneal sarcoma, having to remove the tumor with, in her case, 2 other organs, the adrenal gland and the kidney. She did really well after surgery, recovered in about 3 to 4 days and was home eating and drinking fine. Her kidney function remained normal. And her final pathology, meaning the final results of the operation, were a grade 2 leiomyosarcoma, so similar to her biopsy. Unfortunately, her margins from the surgery, meaning the edges, were negative, so we got the whole thing out for her. And I like her case because it pulls together a couple things for retroperitoneal sarcomas that are important, especially for the surgeons. You know, again, just to really highlight, you know, these are very complicated to remove. It takes a team that has done a lot of these procedures, really understands the nuances of knowing the type of sarcoma before making any sort of particular surgical plan. Because once you go in, you can't go back. And so some of these do really truly benefit from either radiation or chemotherapy before surgery. And so learning that afterwards and discovering that you need something like that after surgery is really not ideal. And so we're extremely thoughtful about that going in. And the other thing that I like to highlight about these is that, again, because they're asymptomatic for so long, you know, they can get quite large. And so the presentations can be very varied from one another. So this patient had reflux symptoms, sort of like early satiety or difficulty with eating, but a lot of patients come in, sometimes they notice the mass themselves. It gets large enough that they can feel it in their belly, or they have difficulties with having their bowel movements. And so because the symptoms can be so varied, it takes a while to really get sometimes to the true diagnosis. And similar to this patient, she came from her primary care physician. We see a lot of patients like that where a couple different providers had seen them looking for reasons why they were having these sorts of symptoms. And finally, we get imaging that lands us on the diagnosis. And so this is a pretty prototypical presentation for something like this. And again, fortunately, she did really well post-operatively. We were very happy with her outcome. And she sees Dr. Lee, who was on the call for we heard discussions regarding chemotherapy. And I think that's a really nice segue. I just want to turn it over to you, Dr. Lee, to maybe offer any comments about chemotherapy for retroperitoneal sarcomas, maybe not just her case, but in general.
Sure. So, you know, I think you heard me talk a little bit about the role of chemotherapy for the extremity and truncal sarcomas, which already is very nuanced and depends a lot on the individual case. For retroperitoneal, this is an area of very active research because so far it has not been as clear cut that the risks of the chemotherapy end up changing people's outcomes or making things better for them, both in terms of kind of recurrence or survival long term. And this is a patient that we actually did offer or now have an option for in terms of clinical trial. We have that on the next slide. It's basically a trial called STRAS-2 that is currently open at our site and many other international sites, trying to kind of really look at this in a systematic way. And many trials have tried to answer these questions before. One thing I'll point out too that this kind of illustrates is just that, you know, sarcoma is such a rare disease that it's sometimes very hard to come up with answers that are enough, that have enough data behind them, because a lot of times finding the number of patients to really kind of compare your treatments, you know, you may not end up coming up with enough statistical power to really kind of answer the question. So this is really one where we are trying to work as an international community to really come together and, hopefully, change the standard of care or kind of clarify what the standard of care should be for patients in these situations. I think the other thing about a kind of a large volume center like Fox Chase is that you have access to these clinical trials. And, I think that that's an important part of trying to kind of make sure patients are getting access and advice on the best, what we know so far in the field. So for STRAS-2, they're looking specifically at retroperitoneal sarcomas. The most common subtypes are the liposarcomas, LPS, or the leiomyosarcomas like this patient. And I think some of the other themes that we see is that sometimes it's also about trying to pick and identify the patients in which we think we will have the best chance of these interventions working. Because, we think that you want to, we see a lot of different range of susceptibility to chemotherapy in all these different subtypes that Dr. Villano mentioned. And so we're trying to find ones where not only do we think that there's a chance the chemotherapy could actually affect this subtype, but also just kind of making sure that we're picking the highest risk, patients who might actually see a change in their, tumor course because of the chemo. So these are kind of patients that before surgery are identified as having these high-risk features based on a kind of combination of the grade and the size of the tumor. They've undergone the appropriate biopsy to identify the type, as we said, and then we kind of try to tailor their chemotherapy for 3 cycles before their surgery. And then, people will either be randomized to kind of go to surgery up front or to get this chemotherapy and then go to surgery at that point. And this is hoping to answer the question of whether that extra kind of, risk of side effects and everything ends up helping people do better long term if we add the chemotherapy up front for retroperitoneal sarcomas. So this patient certainly was offered this and she chose not to participate, but I think that this is going to be the kind of trial and the kind of opportunity that ends up really answering some really key questions in the field.
Thanks, Dr. Lee. I appreciate your comment. And, I really like that we have this available to our patients at Fox Chase, because like you said, we learn a lot about the disease by putting people on trials, and hopefully, in the future, we will have sort of a more tailored experience for folks with retroperitoneal sarcoma. One of the issues with it is that it's beleaguered by something called recurrence, meaning that the tumor comes back in the abdominal cavity in the retroperitoneum, either in the place where we operated on it, or even, believe it or not, sometimes in places remote in the abdominal cavity. And it's a terrible experience for our patients, but also never feels good as a surgeon to see a recurrence. And so trials like this, I think, are going to be the future to really get at that particular issue. And retroperitoneal sarcoma is a type of cancer that, unfortunately, the recurrences are common. And so I'm really glad that we have this open and we're going to learn more. Speaking of the pendulum swinging, there's a lot of active research also in the field of radiation for retroperitoneal sarcoma. And I think we've learned a lot of things in recent years about it, more than we've ever had because of trials like STRASS. And so, Dr. Schulman, and I know you probably have some excellent comments about radiation therapy and what we're doing in the modern times for retroperitoneal sarcomas. So I wanted to see if you have a comment or two for us about that.
Sure, thank you. The role of radiation in retroperitoneal sarcoma becomes very nuanced. It's based on a number of factors. One of them important is, of course, the type of sarcoma you have, but also the size of the tumor, the location of the tumor, become very important in retroperitoneal sarcoma. So we know that certain types of sarcoma are retroperitoneal sarcomas are more sensitive to radiation. They seem to be more effective than others. The classic example is that we know that liposarcomas are more sensitive than leiomyosarcomas, which is why the patient presented didn't receive radiation. But similar to the extremities, radiation can be used to reduce the risk of local recurrence, which becomes important in retroperitoneal sarcomas. In this case, we do have a very strong preference for radiation before surgery if it's indicated or recommended. And that's because, again, we can deliver lower doses and deliver radiation to smaller fields in this case as well, which becomes very important when we're near normal structures like the bowel and stomach, kidney, and so on. So the standard still is 5 weeks of radiation. Again, we are looking into shorter courses of radiation. We have some very exciting technology, which I will be discussing later in the webinar, that allows us to more safely deliver higher doses of radiation and fewer number of treatments.
Thanks, Dr. Schulman. And so again, I think just to tie things together, I think retroperitoneal sarcoma is one of those disease sites that really takes a huge team effort. It's a highly coordinated plan that's made by the radiation oncologists, the medical oncologists, and the surgeons. And every single sort of nuanced maneuver we make for the patient really takes a careful sort of weighing of the pros and cons of each one of these modalities, what's going to be right for the patient, and how it's going to optimize their outcome. And so I thank everyone for sharing their opinions on it, and I will turn over to our last portion of the segment.
Great. Thanks so much, Dr. Delano. So we're going to talk about the patients that I think the medical oncologists see more frequently, which is the patients who have advanced disease that has unfortunately spread. And Dr. Lee is going to talk about a variety of options that we can provide in different scenarios, and also ask Anjali to sort of spend some time talking about how do patients cope when their disease is advancing. So, Dr. Lee.
So, as Dr. Van Maren said, I am the medical oncologist who really mostly probably deals with the patients who are in the advanced metastatic setting the most. And in this case, when somebody has a disease that is not surgically resectable, we are usually talking about treatments that can sometimes control, maybe shrink or stabilize disease, but not usually cure it. And we really, try to focus on talking about things in terms of risks and benefits, and trying to make sure that the interventions we do for people really, help them in terms of living longer, living better, without, giving them unnecessary side effects that really aren't kind of, improving things for them. In general, I would say the mainstay of treatment in this case is systemic therapies, which means they kind of travel everywhere in the body. And that can be kind of traditional chemotherapy, but there's more and more things that are kind of in the targeted therapy categories, and also immunotherapies. And there sometimes is a role for things like surgery and radiation, but it really is more for prevention of complications, or really kind of relieving symptoms, I would say, in those cases. And it has to be really, again, carefully applied to make sure that the people who are undergoing something like that are actually benefiting from it. I guess this probably is a good time to maybe ask Anjali to kind of talk a little bit, because I think that, when people have gone through such a hard course in terms of things like surgery and radiation and chemo, and then kind of are suddenly faced with a recurrent metastatic disease, the mindset can be very different. It can be a very hard kind of, change, and also just kind of helping people to figure out what is important when they're making their decisions about their own care and stuff can be a very difficult transition. And our social workers and our team, just the support from the whole team really matters, I think, a lot in this case. And, Anjali and our social work team has always been very much there for our patients. And maybe you can kind of talk a little bit about some of the issues that are, specific to the advanced metastatic setting.
Thanks, Dr. Lee. So yeah, I mean, there's a lot of different feelings. Some people will say it feels almost like being diagnosed for the first time all over again, because there's this element of grief, there's this element of shock, there's this change of figuring out what to hope for. Initially when most people present, they're hoping for cure. They're hoping for being able to live out the rest of their lives. They're hoping to spend as much time with the people that they love. And then suddenly when you're faced with, changes, or we're not talking about curative treatment anymore, we're talking about controlling the disease, oftentimes there's a grieving process that's associated with that, helping people figure out what it is that is important to them. What can we do to help them make decisions going forward so that we preserve who they are and what's important to them, and also what's important to the people that they love. So oftentimes we have difficult conversations. We talk about things that oftentimes people don't ever even want to think about, much less say out loud. And then we figure out, based on those conversations, how do we help support you through the process? So sometimes that's a discussion just one-on-one with a patient, a social worker. Sometimes it's, family members or whoever makes up that person's support team coming together and talking with us. And then oftentimes it's even bringing in the medical team, like what we call sort of like a family meeting, where we have everybody come together and be a part of the difficult conversations and help make decisions tailored to the patient, but also what's in the best interest of them, not just in the present moment, but going forward.
Thanks so much. I agree with all of that. I'm just gonna, I actually kind of made my section a little bit more like 3 little case vignettes, because I do think that there are a lot of areas where, we have some, new and evolving tools that can really change the course of people's cancer treatment and course. I think that there's just some examples of how they have changed the way we think about individuals, but also the way we think about the field, and also again highlight the benefits sometimes of being at a place that sees a lot of sarcoma. This is a case of a patient that was treated internationally actually a few years ago for what was presumed to be a renal cell or kidney cancer. You can see on this side, this is a normal kidney, and then on the other, on the left side of the screen, is this very large mass that was in the kidney. And so it was resected, as often is the first step for kidney cancer, and she was treated like such. Had a recurrence in the middle screen, in the middle picture, kind of several years later with lung metastases, and got treatments for kidney cancer in a very standard way with a lot of targeted therapies. Had a lot of complications from them. Some of them involved some infections of the chest wall. Some of them was some hearing loss, a lot of things that really just, really decreased her quality of life. She finally ended up coming to Fox Chase after moving to the US, and was, seen in the ER and eventually transitioned to us. And, one of the most important things I say that, people get from coming for a second opinion is really making sure that the whole of the case is reconsidered from kind of start to finish, especially things like pathology, because these are such rare tumors and they're so varied that, sometimes you need a sarcoma specialist pathologist to really be considering the case. And so our pathologist looked at this and really wasn't convinced this was a kidney cancer. And, the standard stains that you look at under the microscope couldn't really prove that one or the other, but we do have tools nowadays in form of molecular testing that can change that. So he sent her tumor for genetic testing and found this kind of more recently discovered fusion that is very classic for a type of sarcoma that is considered an ultra rare sarcoma. And so her diagnosis was changed from a kidney cancer to this sclerosing epithelioid fibrosarcoma, which, has a very different sensitivity to treatments and also just a very different kind of expected clinical course. And, the first thing we did was kind of discuss, what evidence there was for the things that she was already on. And I think the kind of targeted therapies she was on would have worked for kidney cancer, but not really for this type of cancer. And so we took her off them because I don't think they were getting her benefit. And then it was a risk-benefit discussion about other things. She'd already been on an immunotherapy as well because of her from this presumed kidney cancer. And, there isn't necessarily good data for that, but she was tolerating that well. And there's enough kind of, nuance in the literature to suggest that maybe there could be some benefit. And so we talked about that, saying if it's, not hurting you and maybe it's helping you, maybe we can continue that one. We also sent her for a, resection of some of these lung nodules because of the pace of her disease and the fact that she'd had control over several years. That is the person who may get some benefit out of something like a local therapy, like a surgery. A second example of a case where, advanced diseases are really kind of getting new, options because of genetics and molecular testing is this patient that is a young lady who presented with this mass kind of involving the lower part of the stomach, kind of pressing on the esophagus and the edge of the stomach and the blood vessels kind of, in that area. And it wasn't spread at the time that she was diagnosed, but it was so, intimately involved with all these important structures like the blood vessels and everything that it was deemed to not be surgically resectable. But she was losing weight. She couldn't really eat. She couldn't really, get food down past that area. And she didn't really tolerate several lines of standard chemotherapy. But her type of tumor is one called a well-differentiated or a dedifferentiated liposarcoma, which is kind of related to well-differentiated liposarcomas. These are very much characterized by, classic, again, molecular changes where some genes get made into multiple copies. And this is just an example of these kind of copies in the form of rings and rods that you can, this is not the form that we tested in, but you can look for these kinds of things by doing molecular testing. And because of that, there's now, both on and off clinical trial, there are medications that we know can, target these amplified genes and have a very different side effect profile. For her, it was a lot more tolerable, and they can give, good benefit in terms of stability, and she's now kind of able to eat a bit again. She's able to kind of travel out of the country to see her family again. She's gained, 20 pounds since I met her. And overall, I think that, just the fact that this was an option, is something that is new within the last, several years and has been a big help to our patients. The final example I'm going to give is a case of a gentleman who presented with synovial sarcoma. This is a type of sarcoma that can be relatively chemosensitive, and many chemos, I will say that many sarcomas are not very chemosensitive, right? This is one that's on the, more chemosensitive side, but, it's also something where, he presented with quite extensive disease, very symptomatic, had a lot of lung involvement, as well as what we think is his primary here. Is going to start his first line of, standard chemotherapy, which we expect will have a decent chance of response. But I wanted to highlight that there's some exciting things that are hopefully very close on the horizon for synovial and maybe some other, subtypes of sarcoma. There are many studies now looking at kind of engineered immunotherapies, meaning that, can we change the immune system or modify it in a way that makes it, work better in sarcoma? Sarcomas in general are not very immunotherapy responsive, other than a couple of subtypes, but there are some things that are unique about them. One of which is that some of them can express a lot of surface markers that could be good targets for things like a cellular therapy. These are basically engineered T cells. T cells are part of your immune system that normally recognize viruses or also kind of surveil your body for tumors to begin with. And they, normally don't recognize your own body's cells because they're taught that this is good. This is your own body, leave that alone. But we know that tumor cells express things on the surface that are not normal, right? And these cells are kind of especially good at kind of picking up on some of these not normal molecules. So for example, tumor cells like synovial tend to express a lot of this protein called MAGE4 that shouldn't be, it should only be in like, embryonal or kind of pre-birth tissues, right? And in an adult, when it's expressed in an adult cell, that's often a sign that things are not kind of functioning normally. And when people have the right kind of, holder molecule, this red molecule that can express and hold this abnormal protein, these T cells are specifically engineered to go look for that and destroy the tumor cells. This is a technology that is now being developed, for the clinic. It is something where, people's own T cells are harvested by something called leukapheresis and then modified in this way to recognize cells that are tumors expressing these abnormal proteins, and then given a little bit of chemotherapy, and then the cells are reinfused back in to fight these cancers. And these are things that have been showing a lot of promise in trials. They're under priority review by the FDA. And we've been, in talks with the company that makes Afami-cel essentially to, talk about what it would be like to bring this to the clinic once it's clinically available. So these are all kind of, this is an approach, a kind of way of thinking about sarcomas that I think is really novel and hopefully will be a great option for a lot of our patients. I'm going to turn it over to Dr. Shulman just to talk about as well a couple of other areas where advanced sarcomas can really have new options for treatment.
Sure, thank you. We are increasingly, I think, seeing advanced metastatic sarcoma patients in the Radon clinic. We have historically always offered symptomatic patients palliative treatment. So if there are any areas of disease that are causing pain, we can deliver a course of radiation. But recently, I wanted to talk about some advances in our technology and radiation. We're offering something called adaptive radiation, which is essentially when you come in for your treatment, we're able to take a CT scan and real time adjust your treatment based off of where your tumor is and where your normal tissues are that are surrounding the tumor. This is becoming, something that I recommend, especially in patients that are doing really well with their systemic therapy, if they have limited sites of disease. So if you have 1 to 3 sites of disease that are stable, or one area that is increasing and everything else is stable, this is something that we are increasingly offering our patients and is very promising. So these are just some pictures. This is a patient that I actually share with Dr. Lee that I recently treated. to give you an idea of why this technology is so meaningful. So this top picture up here is just a CT scan. This is someone's pelvis. It's a mass in the pelvis, and it's just showing you that this is the tumor in various different colors. I treated this patient, this is their planning scan here, which is called the SIM scan. And this is day 1 to 5 of treatment. And you can see that this tumor is moving significantly every single day. So historically, we would not be able to safely treat a patient like this. The target would be considered too mobile, and we wouldn't be able to give a high enough dose of radiation safely because this tumor is surrounded by normal bowel, and bladder is nearby as well. And this is also just a composite picture here. You can see this is the tumor, the movement. And when we treat these tumors, we're treating the tumor with something like a 3 millimeter margin. So it's very limited. So knowing where the tumor is real time is really, really meaningful. This is, again, just another depiction of the same sort of idea. So this color here is what I ended up giving the patient. That means this is getting full dose. And this this picture here on the left, sorry if you can't see my mouse, I hope you can. The picture on the left where it says scheduled plan is what the patient would have received if we weren't able to adapt the treatment. So it really is a really great way to get pretty large doses safely to very targeted areas. So just something that's new and something that we offer at Fox Chase.
That's great. Thank you all. So we've come to, everybody was on time. Thank you so much. We do have some time to try and answer some questions. I don't see any questions in the chat. I'll give people a couple of minutes to see if they want to put anything in. If not, we can end the session early and people can resume their evening activities. But while we're waiting, I just want to thank my colleagues for their presentations, taking the time to put this all together, and always try and celebrate July, which is Sarcoma Awareness Month. So thank you for sharing in this event with us as we remember all of you and try and make sure that everybody is aware. This event was recorded, so it will be able to be shared in the future, and it will be placed on YouTube, on our channel, and elsewhere. So if you have friends, let them know. It can be seen again in the future. So thanks again. And there are no questions. So I think we'll say good evening, and thank you so much for coming, and thank you again for all of my colleagues who participated. Have a good evening.